invite Dr. Nimitha Najeeb. She is the glaucoma consultant in Compass Eye Hospital, Calicut. She will be talking to us on automated perimetry. What's the right way of doing an automated perimetry? In the meantime, if anybody is interested to have tea, the tea is being served outside and in the dining area, or you can have tea and come back if you want.
So, visual field is all the space that I can see at any given instant. And Trakwar Hill of Vision is the island of vision surrounded by the sea of darkness. So the boundaries of the normal field, visual field is 60 degrees superior and nasal, and inferior 70 and temporal 90, and blind spot is located temporally. There are two types of perimetry, that is kinetic and static. In kinetic, the testing is along the XY axis, that is from the non-seen area to the seen area, and the luminance and the size of the target is changed. Whereas in static, it is along the Z axis, and it is determined, to determine the retinal sensitivity, and the size of the target is the same, but varying brightness. The different types of kinetic perimetry is Goldman, tangent and confrontation, whereas static is HFA and octopus. The unit of measurement of retinal sensitivity is in decibel, and increased decibel it corresponds to decreased light sensitivity projected. And the background illumination is basically 31.5 postals ASB, and the perimetry should be performed in a dim lit room and not in a brightly lit room. So this is how the screen looks like. And whenever the patient is seated, we give a central fixation target, and if there is a central scotoma, a large diamond or a small diamond is basically given. The eye monitoring is basically to locate the blind spot, and the center of the pupil should coincide with the video monitor, and if there is any head tilt, the blind spot is displayed, and if there is more than 20% fixation losses, it is considered unreliable. And in the newer HFA series, there's the gaze monitors, where it is in old HFA machines, this eye monitoring takes 5% of the total test time, whereas in newer HFA machine, the gaze monitoring is less. It takes each position, and the gaze monitoring is this is the below graph shows the gaze monitoring. So while we choose an HFA test, there should be a strategy, and that is, it should be a full threshold CETA or CETA fast, and then there is the program, that is the 30-2, 24-2 or 10-2 macula, or then there is the perimetry techniques, that is either white on white or blue on yellow. And this is how the refractive correction should be given, that is full aperture lenses with narrow metal rim, which should be placed close to the eye, and single vision lenses and spherical lenses should be placed towards the patient's face, and cylindrical lenses towards the bowl. So these are the 10 zones which we take. So zone 1, it includes the patient data and the test data, and in the most common is that the age, all the details should be correctly entered, and the age, the size of the pupil is very much important, and it should, in older HFA machines it is manually entered, and in newer HFA machines it is automatically given. The refractive correction also should be given nicely, others it could lead to generalized depression. The stimulus size which we use is most commonly the size 3, and in advanced glaucomatous damage size 5. So this is a HFA of the patient where there is lot of fixation losses. So the basically this here I would like to highlight is that the wrong done here is that the refractionist has entered the eye wrong. So all the details should be entered correctly, as it will affect the printout. Zone 2, that is the reliability indices, that is, it includes the fixation losses and the false positive errors. False positive errors, basically the patient responds, pushes the button when to a non-projected stimulus, and more than 33% is unreliable, and false negative, it is to failure to respond to the brightest stimulus, and more than 33% is unreliable. So this is seen in basically in an unreliable, in a inattentive patient, or if the patient is fallen off to sleep. Foveal threshold, the normal foveal threshold is 32 to 34. And this is the HFA of where there is a high false positive, which is seen as totally white, and it's a trigger happy patient. And when the false negative is more, then there is a clover leaf pattern seen. So if there is a double excess in the fixation loss and false positive and false negative, it means the test has to be repeated again. So the raw data just gives the retinal sensitivities in dB, and 0 means no response to maximum light intensity, and 40 means response to dimmest stimulus. And grayscale, it is just to look for the general trends. The total deviation numerical plot, it basically gives the difference between the normal retinal sensitivity and the patient retinal sensitivity, and the difference, and it's the probability plot is just the total deviation numerical plot converted to based on the significant probability values, and darker the square, more significant is the defect. Pattern deviation numerical plot, it is to bring out the deep scotomas, and after taking the 7 best retinal sensitivity point, it is added to the total deviation numerical plot, and this is basically important in glaucoma and forms the basis of the glaucoma hemifield test. And its symbolic representation is given in the probability plot. The mean deviation, then the next zone is the zone 9, which is the mean deviation, which gives the overall severity of the field loss, which is represented by the height of the hill of the vision, and pattern standard deviation by the contour, and VFI is given in percentage. So the VFI is basically to detect the rate of progression. The zone 10, that is the glaucoma hemifield test, it just gives the plain analysis of the visual field test, and it is divided into 5, that is outside normal limits, borderline, abnormally low sensitive, abnormally high sensitive, and within normal limits. So this is a normal HFA of the patient, and the next is the next is the glaucomatous HFA, and here you can see that in glaucomatous HFA it respects the horizontal meridian, whereas here there is the neurological defect where it respects the vertical meridian. So this is a small video of how to do the HFA. So after that's the headrest, chin rest, and the adjustment buttons. You should clean, and then you should select the strategy. You should select the eye first, and then you should enter the patient ID, name, date of birth. Next, you should calculate you should enter the refraction details. The computer itself will calculate the trial lens. And next, you should enter the best corrected visual acuity. Followed by you should occlude the non-dusting eye, and then you should explain the procedure to the patient. And after the chin and the head is kept clearly, then you test for the fovea. Foveal threshold is tested, and then the main test is done. And then followed by you save the test, and then after that the next eye is tested.